All right, so today we're going to be talking about antidepressants. Before we get started, big thank you to everybody who's liked any of my videos, who's left a nice comment, who's bought a t-shirt or a mug, subscribed to the channel, everything. I really do appreciate it. So thank you so much for that. Let's talk about antidepressants. So there's a lot with this. There's SSRIs, SNRIs, TCAs, MAOIs, atypical antidepressants. There's a lot to know here, so I'm going to keep it as high yield as possible, throw in a bunch of mnemonics to help you remember what you need to know. Before we get started, let's really quickly talk about a couple basic fundamental concepts that will help you better understand the meds we're going to go over today. Let's start with the monoamine hypothesis. So there's something known as the monoamine hypothesis, which dates back to the 1950s. Basically states that the underlying pathophysiologic basis of depression is essentially a depletion in levels of serotonin, norepinephrine, dopamine, and the CNS. Now, we've learned over the years that ain't all that's going on. There's definitely more to it than just this chemical imbalance, but understanding this basic concept it's actually going to help you better understand the meds we'll go over today and their proposed mechanism of action. So before we start with our first class of meds, let's really quickly run down this whole neurotransmitter exchange in the brain. So we have two neurons close together. One neuron is the presynaptic neuron, the other is called the postsynaptic neuron. They're separated by a teeny tiny space called a synaptic cleft. So the presynaptic neuron, it's got all the goodies depending on which type of neuron we're referring to, serotonergic, etc. It's stocked with either dopamine, serotonin, norepinephrine, and they're all stored in these sac-like little structures called vesicles. So eventually we have to get those neurotransmitters out of those vesicles so they can do their work. So that happens by way of an action potential, which saps this presynaptic neuron, which causes these vesicles to pop open and dump their delicious contents into the synaptic cleft between the two neurons. At this point, these neurotransmitters, dopamine, serotonin, etc., bind to the receptors on the postsynaptic neuron, and they work their magic. And after a period of time, the neurotransmitters that are still hanging out in the synaptic cleft, not really doing much, well, the body's got to clean them up, so some of them will just drift off in a process called diffusion. Other cases, they'll be sucked back into the presynaptic neuron and potentially broken down by an enzyme known as monoamine oxidase. A lot of the meds we'll go over today actually impact this specific area, inhibiting that cleanup process. Some meds either block the reabsorption of these neurotransmitters, allowing them to hang out in the synaptic cleft for longer. Some meds block monoamine oxidase so the neurotransmitters aren't broken down and can be recycled for another go. And we'll dive deeper into that once we break down each individual class of medication. So that's the basics. Now that we have that covered, we'll get started and we'll talk about arguably the most important class of medication that you need to know for psych, and that is your SSRIs, your selective serotonin reuptake inhibitors. If you're going to focus on one class of meds for psych, by all means, let it be the SSRIs. If you get a question and it says, what's the first line med for the psychiatric disorder, and you can't remember which med it is, pick an SSRI and you got a good chance of getting it right. All right, so the meds in this class are Citalopram, Escitalopram, Fluoxetine, Fluvoxamine, Paroxetine, Sertraline. It's a lot of weird sounding similar meds. A lot of these antidepressants are just really difficult to memorize as they all sound so similar. And I usually wouldn't recommend taking the time, but for SSRIs, this would be the one time where I would say to try to make an effort if you can, because they just come up so often. And if you want a way to memorize them, I do have a mnemonic. So when you think of SSRIs, I want you to visualize from now on is a snake charmer. You know, those guys with the flute, makes the snake come out of those little baskets. That's what you're going to associate with SSRI medications from now on. So think of a snake charmer sitting down. He's got a parrot on his shoulder, oddly enough. He's playing his flute, and the snake, also known as a serpent, is slowly escaping the basket. Again, snake charmer sitting down, parrot on his shoulder, playing his flute, serpent is escaping the basket. So sitting down should help you remember Citalopram. It's not the same spelling, but same pronunciation. Parrot should help you remember Paroxetine. And the parrot on his shoulder, by the way, is really fat because Paroxetine is the SSRI associated with the most weight gain of all of the SSRIs. He's playing his flute. Flute helps you remember Fluoxetine and Fluvoxamine. And then remember that escaping serpent. Remember the serpent is slowly escaping the basket. Escaping helps you remember Escitalopram, and serpent helps you remember Sertraline. All right, hopefully that helps remember the snake charmer every time you hear about SSRIs, and you should be able to remember the meds in the class. Let's next talk about the mechanism of action. So now that we know what meds are in this class, let's talk about how they work. The name definitely helps with that. SSRI stands for Selective Serotonin Reuptake Inhibitor. So SSRI selectively inhibit the reuptake of serotonin. So let's start with the word selective because that's actually pretty important. This class of medication has relative little affinity for other types of receptors besides serotonin, unlike some of the meds we'll go over later that target a bunch of different areas, often causing a number of unwanted side effects. The selectivity of this class, it's part of the reason they're so well tolerated and have a relatively benign side effect profile, and also the reason they're often preferred over other classes. So selectivity, definitely important. Now, how do they inhibit the reuptake of serotonin, and why does that matter? Well, we talked about this briefly before. So SSRIs do this by decreasing the action of the presynaptic serotonin reuptake pump. So they essentially block the removal of serotonin from the synaptic cleft for a period of time. It's like if this big vacuum was sucking up all the serotonin from the synapse, SSRIs just come in, plug that up. So in turn, we have more serotonin hanging around for longer. And it was essentially hypothesized that more serotonin meant improved mood, and that's how these meds worked. It was so simple. But in actuality, it's not that simple, and we later realized there's more to it than that, because if SSRIs were solely based on the fact that they inhibit reuptake of serotonin, leading to increased serotonin levels, they'd be effective from day one, as serotonin levels increase really, really rapidly after taking the first dose. But in actuality, the full therapeutic effect of SSRIs usually takes many weeks to manifest. So we know something else is going on here besides the increased serotonergic activity. And I don't think you need to know this for your exam, but it's believed that SSRIs, they also increase production of neuroprotective proteins. They can modify serotonergic receptors, and these added benefits which occur in the weeks following initiation of the meds, that's what's actually thought for the reason for that delayed therapeutic benefit. So for the exam, remember these drugs selectively inhibit reuptake of serotonin, leading to increased serotonin activity in the CNS. But for real life, just kind of realize there's more to it than that. All right, let's talk about indications for these meds. Let's start with the big one, obviously, major depressive disorder, unipolar specifically. When we're talking about pharmacologic therapy for treatment of depression, SSRIs are usually going to be your first-line agents. These are usually going to be what you're going to pick. Now, depending on the comorbidities the patient has, in some cases, you can actually use SNRIs, atypical antidepressants, and serotonin modulators that we'll go over later. They can be reasonable alternatives to SSRIs for initial treatment in some patients, but in general, most patients, you're going to start with an SSRI. All right, so some other indications for the use of SSRIs are generalized anxiety disorder, panic disorder, post-traumatic stress disorder, premenstrual syndrome and premenstrual dysphoric disorder, obsessive compulsive disorder, and then bulimia. This is an important one. So bulimia is another indication for SSRIs, but specifically fluoxetine. That's what you need to remember. It's the only FDA-approved med. Other SSRIs can be used second line, but the only first-line FDA-approved med for bulimia is fluoxetine. This is such an easy test question for them to make, and you'll probably be asked this. So how do you remember this? Well, I have a mnemonic. It's not perfect, but it'll at least help you narrow down the choices on an exam. So bulimia has the word bull in it, which is a cow with horns, and fluoxetine has the word ox in it. Ox is another type of cow with horns. So when you see bulimia, think of an ox as in fluoxetine, the other cow with horns, bulimia, fluoxetine, bull, and ox. The only crappy part about this mnemonic is there's two other meds in the class, paroxetine and fluvoxamine, that also have the words ox in them, but the rest of the SSRIs do not, so it at least helps you narrow down the answer choices. So when they ask you, what is your first line med for bulimia, be thinking of a bull, then remember your other cow with horns, ox, and look for that med with the word ox in it, and should help you narrow it down. So there are some other indications, but those are the main ones you'll likely be tested on. That's what you need to be aware of. Let's move on to our adverse effects. So SSRIs, they're selective, as we discussed before, mainly just affecting the serotonin receptor and not really messing around with any of the other stuff like cholinergic receptors, the exception being paroxetine. Anyways, because of the selectivity, they have a relatively benign side effect profile, which is good. With that being said, though, they still, of course, have some side effects. So let's talk about the ones you need to know for your exam. Let's start with the black box warning, as you always need to know any black box warning for any medication class. So SSRIs may increase the risk of suicidal ideation in children, adolescents, and adults younger than 25 years of age. This does not seem to be the case in older adults, but patients 24 and under, be aware of this black box warning. Now, this black box warning, it's not just for SSRIs. In 2004, the FDA actually issued this black box warning for all antidepressant classes, SSRIs, SNRIs, TCAs, etc. So this isn't unique to SSRIs, and I'm not going to bring this up with every single class, med class we're going to go over for the sake of time, but just be aware this is a risk with all antidepressants in your younger patients. All right, next is going to be QT prolongation. This is a very important one when it comes to QT interval prolongation. The biggest culprit by far is citalopram. You need to know citalopram can cause QT interval prolongation. Escitalopram, it's a close second. Studies are not as convincing. And then all of the other SSRIs, minimal to no impact on QT interval. So you really just need to focus on these two, especially citalopram. They're going to ask you this at some point on an exam question. So when you see an exam question that asks which SSRI should be avoided in a patient with long QT syndrome, I want you to think of this sentence. If you long for quiet time, you need to escape the city. If you long for quiet time, you need to escape the city. Long for quiet time helps you remember long QT. Escape helps you remember escitalopram. And city helps you remember the most important of all, citalopram. So again, if you long for quiet time, you need to escape the city. That's going to help you remember your SSRIs associated with prolongation of the QT interval. Another one is sexual dysfunction. It's one of the most common adverse effects of SSRIs. It's been estimated that sexual impairment occurs in roughly 50% of patients treated with SSRIs. Occurs in both men and women, includes decreased libido, decreased arousal, delayed orgasm. Sometimes this gets better as the weeks go on. Sometimes you need to decrease the dose. Sometimes you need to change the med. In some cases, though, those side effects are actually beneficial for certain patients. For instance, SSRIs are considered first-line treatment for men with premature ejaculation. So, sexual dysfunction, another big one you need to know. Serotonin syndrome, it's a potentially lethal condition, usually results from an interaction between multiple meds that increase serotonergic neurotransmission. It's not specific to SSRIs, as this can be caused by pretty much all of the antidepressants we'll go over today, all of the serotonergic agents, but SSRIs are one of the more commonly implicated groups of meds leading to serotonin syndrome. They're usually associated with a fairly benign course compared to other classes like MAOIs, which can be fatal. We'll talk about more about that later. Next, hyponatremia. SSRIs are associated with SIADH and hyponatremia. The risk is pretty low, but you want to be careful prescribing these to patients who are at high risk for hyponatremia, such as your older patients, patients taking diuretics, etc. And then finally, we have weight changes. So SSRIs can be associated with weight gain. It's usually not a significant amount of weight, and in some cases, it's not really clear whether it was caused from the med or the weight gain was just a result of recovery from depression. But it is possible to see some weight gain with SSRIs. Fluoxetine usually causes the least amount of weight gain, and then paroxetine usually causes the most weight gain. Remember that fat parrot to help you remember paroxetine causes the most weight gain of the SSRIs. Now there's other ADRs, nausea, headache, insomnia, bleeding, but for the exam, the ones I went over, those are likely to be tested on, so focus on those. All right, let's talk about our next class, the serotonin norepinephrine reuptake inhibitors, your SNRIs. Included in this class is Desvenlafaxine, Duloxetine, Levomilnacipran, Milnacipran, Venlafaxine. So there's 5 meds in this class, but if we're being real for an exam, I'd really just focus on 2. Duloxetine and Venlafaxine. Know those well, especially Duloxetine. That's what you're likely going to be tested on. Honestly, if you just remember Duloxetine, you'll probably know all you need to know about SNRIs. That's usually what's tested on. Mechanism of action, they block the presynaptic reuptake of serotonin and norepinephrine. Very similar to SSRIs. SNRIs inhibit the reuptake of serotonin, but they also inhibit the reuptake of norepinephrine. They do this by binding to and inhibiting the serotonin and norepinephrine transporters on the serotonergic and noradrenergic neurons. They're also technically weak inhibitors of dopamine reuptake, but the effect is pretty minimal. I wouldn't worry about that. Main effect is on serotonin and norepi. Now, you probably don't need to know this, so if you just shut off your ears if you want to, but how well these meds affect norepinephrine or serotonin, it really depends on the drug and the dose. For instance, I just find this interesting. Venlafaxine at low doses, it's essentially just an SSRI. It really just affects serotonin, where in contrast, high doses of venlafaxine really significantly affects norepinephrine. So just a little extra knowledge. Again, SSRIs, as we talked about before, they were just affecting one neurotransmitter, serotonin. SNRIs, we have effects on 2, serotonin and norepinephrine. So you'll notice a little bit of overlap when we compare these to SSRIs, indication, adverse drug reactions, but then there's also going to be some differences, and we'll talk about that shortly. So let's talk about the indications next. A lot of overlap compared to SSRIs. Major depressive disorder, again, just like SSRIs. SNRIs are obviously indicated for treatment of depression. You might wonder if a class that affects both serotonin and norepi would be more effective than SSRIs, which only affect serotonin. The answer is yes. SNRIs have been proven to be a bit more efficacious than SSRIs, but the advantage is fairly small. With that being said, SSRIs are still usually preferred first line for depression, but SNRIs are reasonable alternatives for initial treatment in certain patient populations. SNRIs are also indicated in generalized anxiety disorder, post-traumatic stress disorder, panic disorder. They're usually second line treatment after SSRIs. So a lot of similarities when comparing the indications of SNRIs to SSRIs. And when things are the same, usually that's not what's going to be tested on. What's usually tested on is unique aspects of a class of medication, and what makes SNRIs different than SSRIs and what you really need to be familiar with is their ability to treat chronic pain syndromes. So diabetic peripheral neuropathy, fibromyalgia, chronic musculoskeletal pain. SNRIs possess analgesic qualities that we did not see with the use of SSRIs, and this is likely due to the fact SNRIs also target norepi, as we discussed. This neurotransmitter likely plays a role in some form of pain modulation. This is the main difference to know for indications, as the rest, they're really just a repeat from the SSRIs. SNRIs, in addition to treatment of depression, anxiety, etc., they have a dual purpose for treating chronic pain syndromes. So you really need to remember that. And the SNRI you really need to know, like I talked about before, is Duloxetine, because the other SNRIs have indications for some chronic pain syndromes, but Duloxetine has the largest evidence-based to support analgesic efficacy and is FDA approved not only for fibromyalgia, chronic lower back pain, osteoarthritis, but diabetic neuropathy as well. So it's the one you really need to know, and it's the one they'll test you on. The way that you remember that is by, instead of remembering Duloxetine, remember it as Duloxetine, as it's dual indicated for both major depression as well as chronic pain. And you can also remember it as Duloxetine because it's a dual action agent that has an effect on both serotonin and norepinephrine. So remember Duloxetine instead of Duloxetine. Let's talk about our adverse effects or adverse drug reactions. So SSRIs, SNRIs, they're pretty similar as they're both pretty specific, meaning they have little to no effect on your alpha adrenergic receptors, your cholinergic, histamine receptors. And because of this, like SSRIs, they have a fairly clean side effect profile. Their side effects are pretty similar to the SSRIs. There's a lot of overlap. So I'm not going to waste your time with the similarities. Just like in SSRIs, they can cause hyponatremia, nausea, sexual dysfunction, serotonin syndrome, bleeding, same black box warning for increased suicidal ideation in young adults. But what you should focus on is what's different. And this class, because it affects an additional neurotransmitter, norepinephrine, causes a new issue that we didn't see with SSRIs. And the main one to know is going to be hypertension. So this one's unique. SNRIs cause hypertension, which appears to be due to their effect on norepinephrine. So it's different compared to SSRIs, and this is the one that I would really focus on. All right, so quick recap. Remember, SNRIs have dual effects. They target not only serotonin, but norepinephrine. Remember, they not only treat depression, but chronic pain syndrome. Duloxetine is the main one to know, aka Duloxetine, and for ADRs, focus on hypertension. Let's move on to some bad meds next, tricyclic antidepressants or TCAs. These were developed back in the 1950s, starting with imipramine, and they became first-line treatment for close to 30 years for depression. So why did we stop using them first line? It wasn't because of the lack of efficacy, quite the opposite, as they were and still are very effective for treating severe depression. But the same thing that makes them so effective, being really broad spectrum, interacting with so many neurotransmitter systems, it's also the same thing that makes them so dangerous, as they have numerous side effects. They have a very low threshold for overdose. So due to this class of meds has fallen out of favor, and it's been replaced by newer, safer classes like the SSRIs and SNRIs. All right, let's talk about the meds that are in this class. So there's two main groups TCAs are broken up into. Your tertiary TCAs, as they're known as, which include amitriptyline, clomipramine, doxepin, imipramine, and trimipramine. And then you have your secondary TCAs, which is desipramine, nortriptyline, and protriptyline. There's a lot of meds in this class. There's not a good way to memorize all of them, and I strongly suggest against trying to do so. If you want to memorize just one, though, let it be amitriptyline. And if you're feeling a bit more ambitious and you want to remember a few of the high-yield meds in this class, just remember you're tripping if you're thinking about prescribing a TCA. You're tripping, TRIP space PIN, if you're thinking about prescribing a TCA. TRIP helps you remember amitriptyline, nortriptyline, protriptyline, and PIN helps you remember doxepin. That's literally all I remember from my exam, and it was enough to help me get the question right. I happened to get a question on doxepin on one of my exams, so just remember that. Should be enough. You're tripping if you're thinking about prescribing a TCA. All right, so now that we know the meds in this class, let's talk about how they work. So TCAs, they inhibit serotonin and norepinephrine reuptake. So you're probably thinking, that sounds a whole lot like how SNRIs worked, and you're right. SNRIs inhibited serotonin and norepinephrine reuptake, but the difference is they did this very selectively and very precisely. Kind of tiptoed in, did what they needed to as not to disturb other systems in the body, which is why they have a very clean side effect profile. TCAs, on the other hand, they come in like a wrecking ball, not only affecting the intended targets, serotonin, norepi, but also affecting the muscarinic receptors, histamine receptors, as well as others, which cause a bunch of unintended side effects we didn't see with SNRIs. So the difference really is about the selectivity of the class or lack thereof. Indications for TCAs, this is not very high yield, and I would not waste a lot of time here as many other classes have replaced TCAs as first-line agents. But sometimes these still do come up on exam questions, so I guess let's run through the indications real quick. Major depressive disorder, let's start with depression. These are not first-line meds for depression. You will not use a TCA for depression. This is not going to be the answer on the test unless they specifically mention they've tried and failed multiple other classes, SSRIs, SNRIs, etc. They're still called tricyclic antidepressants, but you're generally not going to use them for depression unless all else fails due to their poor side effect profile. Next, obsessive compulsive disorder, clomipramine. Clomipramine can be used for treatment of OCD, but SSRIs are first line. Clomipramine is just another treatment option if SSRIs prove to be ineffective. Diabetic neuropathy, TCAs can be used. Amitriptyline, nortriptyline are some common options. Can be used for migraine prophylaxis. Amitriptyline, though, specifically, it's the only TCA that has proven efficacy for migraines. There's really insufficient data with the other TCAs. Nocturnal enuresis, aka bedwetting. You can use imipramine. It's not first line, desmopressin is, but if the child has tried and failed other treatment options, including desmopressin, imipramine is a second line option. I used to remember it as Imapien instead of imipramine, just to help remember that indication, but you probably won't even be asked about this. And then finally, postherpetic neuralgia. Usually you start with gabapentin or pregabalin as initial therapy, but TCAs are reasonable second line options. So I'm sure you notice a trend here. These are usually going to be backup options. Indications for TCAs, not really high yield. I don't think you should waste a lot of time memorizing them, as in general, there's better meds for most of these conditions you should be focusing on. So where you should be focusing on when it comes to TCAs, though, and where the questions are going to come from, is with their adverse effects. So TCAs, like we touched on before, they got some side effects, and the side effects, they get tested on a lot. So let's talk about what you need to know and a little mnemonic to help you remember it. So with TCAs, I want you to focus on that C in TCAs to help you remember the 5 C's mnemonic I came up with. So the 5 C's for adverse effects of TCAs stand for cardiac, QT, chubby, convulsions, and anticholinergic. So what do these mean? Let's start with the first C, cardiac. So all of the TCAs are potentially cardiotoxic. You want to avoid this class in susceptible individuals with heart disease. TCAs can slow intracardiac conduction, cause various arrhythmias, orthostatic hypotension. And then the most important cardiac adverse effect that you need to remember, it's so important it gets its own C, is QT. QT, C-U-T-I, should help you remember QT prolongation, QT prolongation. So this is a major concern with TCAs, especially when you mix these meds with other classes that can prolong the QT interval, like certain antimicrobials, antiarrhythmic drugs. So QT helps you remember QT prolongation. Next C stands for chubby. Pretty straightforward, exactly what it says. The cyclic antidepressants block histamine receptors, which can cause increased appetite, leading to weight gain. Next C, very important one, convulsions. All of the TCAs can lower seizure threshold. This is dose dependent, so the higher the dose, greater chance of a seizure, especially in overdoses. So convulsions, aka seizures. And then the last C, one of the most important, So we touched on this before. TCAs, they're not very selective and they can affect a number of neurotransmitter systems. One of those is your muscarinic receptors. TCAs block the muscarinic acetylcholine receptors, which causes anticholinergic effects. So these patients may have dry mouth, urinary retention, confusion, blurred vision, tachycardia, etc. So remember, anticholinergic for the last C. So those are your 5 C's of TCAs that you need to know: cardiac, QT, chubby, convulsions, and anticholinergic. If you know those, you should be good for the exam. Now, one last thing to be aware of is the potential for overdose with TCAs. So TCAs have a high potential for overdose, especially when we compare them to SSRIs. For instance, as little as 10 times the daily dose of a TCA can be fatal. Compare this to SSRIs, where it usually takes an extremely large dose, usually greater than 150 times the daily dose to prove fatal. So when a patient overdoses on a TCA, it can lead to anticholinergic toxicity, seizures, but most concerning is it can prolong the QT interval. So you can give them benzos to control the seizures, but the most important therapeutic intervention and the right answer on an exam to treat a TCA overdose is going to be sodium bicarb. You need to know this. Sodium bicarbonate is the standard initial therapy for TCA overdose with hypotension, arrhythmia, QT prolongation. This is the intervention you need to know for TCA overdose. This is what they're going to ask you. So the way that you remember that is you remember a tricycle is a small bicycle. Tricycle is a small bicycle. Tricycle helps you remember tricyclic antidepressant, and small bicycle helps you remember sodium bicarbonate. So remember, if they ask you how are you going to treat a TCA overdose, remember sodium bicarbonate, aka a tricycle is a small bicycle. Let's move on to another bad class of medications we don't really use so much anymore. That's our monoamine oxidase inhibitors, our MAOIs. MAOIs, like TCAs, they were one of the first drugs developed to treat depression. We discovered this class really by accident. Back in the 1950s, they were trying to develop a drug to treat tuberculosis, a drug called iproniazid. During the study, they found other potential benefits outside of its intended purpose, as some of the patients in the study exhibited improvement in their mood. So this med kicked off the MAOI class, and while iproniazid was later removed from the market due to hepatotoxicity, it was replaced by the other meds we'll go over today. In general, MAOIs, like TCAs, they're rarely used anymore because of their side effects, food and drug interactions, and quite simply just because we have better and safer options now. In general, these meds are really only going to be used for refractory cases where nothing else has worked. So the meds in this class are tranylcipramine, isocarboxazid, phenelzine, Selagelene. This comes in both an oral and transdermal formulation. You can remember the meds by remembering the TIPS mnemonic because they start with TIPS. Little mnemonic to help you remember the meds in this class. There's another one, moclobemide or moclobemide. It's not available here in the US though, so I wouldn't really worry about that one, but focus on the TIPS meds. So how do these meds work? Let's talk about the mechanism of action. So they increase dopaminergic, noradrenergic, and serotonergic neurotransmission by blocking something known as monoamine oxidase. So to understand how these meds work, we need to talk about monoamine oxidase and understand exactly what that is. So most of the other antidepressants we discussed so far, they worked by decreasing reuptake of the neurotransmitter, serotonin or epi, etc., which in turn left more of them hanging out in the synaptic cleft to be utilized. But MAOIs, they work differently. So once serotonin, norepi, or dopamine have already been reabsorbed by those reuptake proteins, some of those neurotransmitters get packaged into vesicles, waiting for the next go-around to be released into the synaptic cleft. But a good portion of those neurotransmitters, they're broken down before they get that opportunity, and they're broken down by an enzyme called monoamine oxidase. We briefly touched on this at the beginning. So monoamine oxidase is a mitochondrial enzyme. It's found in the brain as well as a number of other organs, and one of its jobs is to inactivate or break down dopamine, norepinephrine, or serotonin once they've been pumped back into the presynaptic cleft. So the more we inhibit monoamine oxidase, the more neurotransmitters are available for the next go-round. There's another side note with this. There's actually 2 different types of monoamine oxidase A and monoamine oxidase B. They both break down neurotransmitters. Monoamine oxidase A metabolizes more neurotransmitters compared to monoamine oxidase B. Wouldn't really worry too much about that though. But different meds in the MAOI class can be selective in that they only inhibit one type of monoamine or another. So some are non-selective, in which they inhibit both types of monoamine, and our non-selective agents are going to be isocarboxazid, phenelzine, and tranylcipramine. So non-selective, again, meaning they inhibit both MAOA and MAOB. And then we have selegiline, which can technically be non-selective or selective depending on if it's high or low dose. But for the sake of the exam, it's best to just know it as a selective agent. So selegiline at lower doses, around 5 to 10 milligrams, selectively inhibits only MAOB. And due to this, it's not really effective for treatment of depression, but it can be used for Parkinson's disease due to its effect on dopamine. Even that's a little controversial at this point, so I don't want to go too deep into that. But just kind of know if you see this medication on the exam, usually it's going to be referring to its treatment for Parkinson's disease rather than for depression. There is a transdermal patch version of selegiline that's used for depression, but I wouldn't really worry too much about that. If you see selegiline, just know they're probably talking about its indication for Parkinson's disease rather than depression. All right, so let's talk about the indications for MAOIs. Is there really anything we're still using these meds for? So the short answer is no. For the exam and for real life, you're really not going to pick an MAOI. These meds are really only used when all else has failed. And just like in TCAs, it's not that these meds don't work. They actually work very well. They just have too damn many dangerous side effects. So I wouldn't really bother memorizing indications for these meds. It's unlikely to be tested on. Let's just briefly run through the indications. But again, I wouldn't memorize this as this is not where you're going to be tested. So depression, unipolar depression, you can use an MAOI, but only when the patient is unresponsive to several other pharmacotherapy regimens, different SSRIs, SNRIs, etc. This is not going to be first line. This will never be first line. Other indications, refractory cases of panic disorder, social anxiety disorder, bulimia nervosa. The key here with all of these conditions, it's again, MAOIs, they're not first line meds, only for refractory cases. So probably best to just mentally skip the indications for MAOIs, leaving some space in your brain for something more important, such as the highest yield thing to know about MAOIs and what you'll likely get tested on, and that's their adverse effects. So let's talk about that next. So MAOIs, they can cause blurred vision, constipation, dry mouth, headache, liver enzyme elevation, orthostatic hypotension, insomnia, sexual dysfunction. But that's not what they're going to ask you about. What they're going to ask you about are the drug-to-drug interactions that can cause serotonin syndrome and the drug-to-food interactions that can cause a hypertensive crisis. That's the juicy stuff you need to know for exams. Let's start with probably the most important of all, and that's a hypertensive crisis. So if you take an MAOI and eat some cheese, you can have a hypertensive crisis and potentially die. So hopefully it's becoming a bit more clear why we really don't use these meds so much anymore. So let's elaborate on this a bit. So monoamine oxidase, as we discussed before, it's not just found in the brain, it's found all over the body, including the lining of the gut wall. And one of its jobs in the GI tract, mainly MAOA, is to break down something called tyramine. But in a patient taking an MAOI, as we know, this drug inhibits monoamine oxidase, meaning tyramine isn't broken down as it should be. So why does that matter? Well, tyramine or tyramine in high concentrations can increase norepinephrine release. Norepi can cause vasoconstriction, increased heart rate, and can cause a rise in blood pressure, which can precipitate a hypertensive crisis. So long story short, MAOIs combined with foods that have a bunch of tyramine can cause your BP to go sky high. So you want to avoid that. Now, what foods have a lot of tyramine in them? The main ones are cheese, meat, poultry, fish, beer, and really any aged or fermented food. We don't see this as much as we once did because a lot of foods have changed. You know, the food processing is getting better and things like that, but it still can be seen. And if you want a way to remember the foods that are high in tyramine, I have a way for you to remember this if you're a Game of Thrones fan. If you're not, this may not help. So if you're a Game of Thrones fan and you remember Tyrion Lannister, Tyrion, he liked his tyramine-rich foods, beer and alcohol, as well as other classic medieval foods, cheese, meats, fermented or spoiled food. So if you can't remember which foods are high in tyramine, just think, what did Tyrion Lannister eat and what did he eat and drink back in those medieval times? And that's your answer. At least that's how I remembered it. All right, so last thing that you need to know, these meds can cause serotonin syndrome. So yes, all of the meds we went over today can potentially cause serotonin syndrome. So this isn't something unique to MAOIs, but what is unique to MAOIs and why it's often tested on is that episodes of serotonin syndrome involving an MAOI versus other classes are generally much more severe and could potentially be fatal. So you want to be really careful with this class of medication. You never want to mix an MAOI with another serotonergic agent like an SSRI, SNRI, etc. That's really important. All right, so there's a lot of other side effects for MAOIs, but be sure to really focus on your hypertensive crisis with tyramine-rich foods and serotonin syndrome. That's what you're going to be tested on. All right, so we're almost there. There's 3 other antidepressants I want to go over briefly that don't fall into any of the above classes, but they come up very frequently in exams. So let's just go over them really quickly because they have a few high yield points that you need to know. The first is going to be bupropion. This is a really high yield med to know. Bupropion is considered an atypical antidepressant. Atypical, as the way it works, is distinct from the other classes we have gone over thus far, SSRIs, SNRIs, etc. What you'll find with these atypicals is they have some unique characteristics that can make them desirable for certain patient populations. You'll see what I mean in a minute. So how does this medication work? How is it different? Well, bupropion inhibits presynaptic reuptake of dopamine and norepinephrine, which leads to increased levels of these neurotransmitters within the synaptic cleft. Now, how is that different than the other antidepressants we've gone over so far? The main difference you'll notice is bupropion has little to no effect on serotonin. Unlike all of the other classes we have gone over thus far, SSRIs, SNRIs, TCAs, etc., which had an impact on serotonin, bupropion does not, and its main effect is only on dopamine and norepi. All right, so there's a few other high yield things to know for bupropion, and I really recommend committing these to memory because they really like to make exam questions on this drug. You really should know it. But luckily, everything you need to know about bupropion starts with the letter S, at least it does for my mnemonic. So here's the 4 S's you need to know for this medication. Those are seizures, smoking, skinny, and sex. You're very likely to get a question on one of these, so let's break them down, starting with the first S that stands for seizures. This is probably the most important thing to know. Bupropion can cause generalized seizures. The higher the dose, the higher the risk of seizure. So you want to avoid using these in patients at risk for seizures. So patients withdrawing from alcohol, benzos, barbiturates, etc. And then the highest yield patient population that's at risk for seizures, the one that's always tested on, is patients with a history of eating disorders. So anorexia, bulimia, they always ask questions on this. So you need to know you do not use bupropion in patients at high risk for seizures, especially patients with eating disorders. You can thank me later when you get this question right on your exam because they're going to ask you about it. Next, S stands for sex. Bupropion is the antidepressant of choice if you want to avoid sexual side effects. So you have a patient who is concerned about sexual side effects and is going to start an antidepressant, or maybe a patient who's already experiencing sexual side effects from an SSRI, switch them to bupropion. There's even some studies that show benefit from adding bupropion to an existing SSRI that a patient's taking to help mitigate the sexual side effects experience. So definitely know this one. It will also likely be tested on. I used to remember if you add an M to bupropion after the U, it made bupropion. Bump because it's the antidepressant of choice if you want to bump and grind. So remember, bupropion instead of bupropion. All right, next S stands for smoking. Pretty straightforward. Bupropion is one of the first-line pharmacotherapies that can be used to assist with smoking cessation. This is another important S. And then the last S stands for skinny. So bupropion, unlike some other classes, does not generally cause weight gain. In fact, a meta-analysis found that on average, patients taking bupropion lost approximately 1 kilogram. So if you have a patient who's fearful of weight gain with the other classes, this is another compelling reason to use bupropion, as it can cause weight loss. And they actually have a weight loss medication called Contrave, which is just a combination of bupropion and naltrexone. All right, so if you remember those 4 S's for bupropion, very likely you'll get the question right. Again, seizure, sex, smoking, and skinny. Next atypical to know is mirtazapine. There's not a lot to know for this one. One major point we'll go over in a second. So let's start with the mechanism of action for mirtazapine. It's a bit complex. There's a lot going on. I don't think you need to know all of the specifics, but the main thing to know is that this drug antagonizes presynaptic alpha-2 adrenergic receptors and postsynaptic serotonin 5H2 and serotonin 5HT3 receptors. So I'm going to break this down, but for the exam, if you can just remember that the drug antagonizes alpha-2 receptors, it's probably going to be enough to get the question right, but we'll dive a bit deeper just for the sake of understanding. So let's start with the alpha-2 adrenergic receptors. We didn't talk about these receptors yet because most of the other antidepressants didn't work on this specific area. Alas, why this is considered an atypical antidepressant. But alpha-2 adrenergic receptors, they're mainly found on the presynaptic neuron, and they work primarily through a negative feedback loop. For instance, when norepi is released, some of it binds to these alpha-2 receptors, which in turn inhibits further release of norepinephrine. So this medication blocks these receptors so that negative feedback loop is shut off, and in turn we have more norepinephrine released, as well as serotonin through an additional pathway. So that's a good thing. In addition, this medication also has an antagonistic effect on postsynaptic serotonin 5H2 and serotonin 5HT3 receptors. So it blocks certain receptors, which sounds counterintuitive. blocking serotonin receptors, but by blocking these two receptors, redirecting it away from 5-HT2 and 5-HT3, this allows them to bind to the more useful 5-HT1A receptor, which has a stronger effect on depression. This medication also has a high affinity for histamine H1 receptors, which accounts for some of its side effects. This is a complicated mechanism. I don't think you need to know all of this. You honestly probably won't even be asked about the MOA on the exam, but there's one thing you really have to know that they'll likely ask you about. The main and possibly the only thing you need to know from mirtazapine is that it stimulates appetite and causes weight gain. This is so high yield, I definitely got a question on it. Mirtazapine can have a big impact on appetite and can cause significant weight gain, up to a 7% increase in body weight. This can be seen in short and long-term use. Remember that, it's always asked about. So how are you going to remember that? Well, instead of remembering it as mirtazapine, I want you to instead remember it as miltazapine. Miltazapine, because remember, this can stimulate appetite, making patients finish their meals and gain weight. One other less important side effect to be aware of is that it can also cause sedation. Close to 20% of patients will have drowsiness or sedation, which likely due to the high affinity for the histamine H1 receptors like we talked about before. But focus on weight gain. That's the most important thing to know for the med. That's what they're going to ask you about. Last antidepressant we're going to go over is Trazodone. So Trazodone is in a class of meds called serotonin modulators. There's a few other drugs in this class, nifazodone, vilazodone, but Trazodone, that's the one you're going to get tested on most likely. So Trazodone inhibits presynaptic serotonin reuptake and acts as an antagonist at the 5-HT2A and 2C serotonin receptors. I know the MOA for all of these is a bit complicated. So both of these mechanisms we've actually gone over with other meds. So Trazodone weakly inhibits presynaptic serotonin reuptake. So same thing that we saw with SSRIs, blocks reuptake of serotonin. So we have more serotonin hanging out in the synaptic cleft to do its thing. Then the drug also blocks serotonin receptors, specifically 5-HT2A and 5-HT2C receptors. We talked about this with mirtazapine, basically redirecting serotonin away from certain receptors, causing them to bind with potentially more useful ones. Now, Trazodone, it's a bit sloppy. It also affects alpha adrenergic receptors and histamine H1 receptors, which causes some high yield, very often tested on side effects you need to know for your exam. This is another drug where the side effects are the most commonly tested on aspect of the drug. First thing you need to know is sedation. A study found that 61% of patients taking Trazodone experienced sedation. This is likely due to the strong effect this medication has on histamine H1 receptors. You're often going to see this medication being used off-label for patients with insomnia. You'll definitely see that out there in practice. So this is one you need to know. And then the other side effect you need to know, it's rare, but a serious side effect, and it's often tested on, is priapism. So priapism, a persistent erection, while rare, can happen with this medication. It's a medical emergency, and it's not common, but they love to test on it. And it has to do with the medication's effect on alpha adrenergic receptors. So you definitely need to know both of these side effects because they're going to be on your exam. The way that you're going to remember them is by, instead of remembering Trazodone, remember Trazobone. So Trazobone, Traz with a bunch of Z's to help you remember the sedation commonly experienced with this medication, and bone to help you remember priapism, the boner that just won't quit. So those are the two high yield things to know for this medication. That's what's likely going to be tested on. So remember Traz with a bunch of Z's, a bone, and you should be good. All right, so that's your antidepressants. It's a lot. Stick to the unique high yield stuff we went over and you'll be all right. Let's do 5 quick questions to see what you've retained. Question 1. A 67-year-old male presents to the office today complaining of persistent low mood, anhedonia, and feelings of hopelessness that have been affecting his daily life for the past several months. Additionally, he reports tingling and burning pain in both of his feet over the past few years and is seeking medication to alleviate this. Patient has a history of type 2 diabetes, hyperlipidemia, and diabetic neuropathy. His current medications include glimepiride and rosuvastatin. Patient is diagnosed with depression and the decision is made to initiate pharmacotherapy. Which of the following choices would be most appropriate for the patient mentioned above? A. Mirtazapine, B. Bupropion, C. Duloxetine, D. Escitalopram, or E. Fluvoxamine. So I'll give you a second to think about that and it'll give me a second to catch my breath. So that is going to be C. Duloxetine. So we have a bunch of different medications that could all potentially treat this patient's depression, but the question mentions this patient has untreated diabetic neuropathy evident by the tingling and burning pain in his feet, which he's also seeking treatment. And there's only one medication listed here that can treat both his depression and neuropathic pain, and that is Duloxetine. Duloxetine, as we know, it's an SNRI that's often preferred in patients with comorbid depression and chronic pain conditions such as diabetic neuropathy. So remember, instead of duloxetine, remember duloxetine for the dual indication of both depression and chronic pain, making it an appropriate choice for this patient. Question 2. The decision is made to initiate antidepressant therapy in a 28-year-old female with a recent diagnosis of major depressive disorder. Past medical history includes hypertension, hyperlipidemia, and celiac disease. She states her friend found great success with Citalopram and was wondering if she could try this medication. Upon reviewing her past medical records, you find a family history of unexplained syncope and sudden cardiac arrest. What should be ruled out before starting this patient on Citalopram? Give you a second. So that is going to be QT prolongation. So Citalopram is an SSRI, and one of the biggest concerns with this medication is QT prolongation. You want to avoid this medication in patients with congenital long QT syndrome or any other risk factors for prolonged QT syndrome. So you have a patient that has a family history of unexplained syncope, sudden cardiac arrest. This patient definitely needs a workup to ensure she doesn't have congenital long QT syndrome given her family history. Remember, the SSRIs where QT prolongation is a concern, Citalopram first and foremost, and Escitalopram. And you remember that sentence, if you long for quiet time, you need to escape the city. You'll never forget the SSRIs that carry a risk for QT prolongation, long for quiet time, long QT, escape, Escitalopram, city, Citalopram. Question 3. A 32-year-old male with a history of depression has been treated with Sertraline for the past 6 months. He initially showed improvement in his mood, but developed bothersome sexual side effects, including decreased libido and difficulty achieving and maintaining erection. In response to these side effects, you decide to decrease the SSRI dose, but the sexual side effects persist. Which medication would be most appropriate to replace Sertraline in this patient? A. Citalopram, B. Bupropion, C. Fluoxetine, D. Paroxetine, or E. Venlafaxine. So that is going to be B. Bupropion. So Bupropion, it's an atypical antidepressant, and as we discussed before, it doesn't have the same sexual side effects that we saw in SSRIs, and it's very commonly the antidepressant of choice for a patient experiencing sexual side effects. So remember, Bupropion instead of Bupropion, as it's the antidepressant of choice if you want to bump and grind. All the other choices are SSRIs or SNRIs, which all carry the risk of sexual side effects. Question 4. 58-year-old male is spending a night out with friends, celebrating a recent promotion. He's enjoying a few beers as well as some appetizers of aged cheese and cured meats when he begins to experience headache, nausea, and chest pain. Paramedics were called to the scene and his blood pressure is reported to be 184/122. He reports he was recently started on a new medication for his refractory depression, but does not recall the name. Which of the following antidepressants is he most likely taking? A. Sertraline, B. Mirtazapine, C. Amitriptyline, D. Phenelzine, E. Escitalopram. So that is going to be D. Phenelzine. So we know this is a hypertensive crisis. We know this was caused by an MAOI due to the high amounts of tyramine he consumed, beer, cheese, etc. So really all we have to figure out at this point is which one of these meds is an MAOI. So even if you can't remember the names of the MAOIs, if you can at least remember the mnemonic TIPS, TIPS, you can narrow it down. So we talked about this before. All of the MAOIs, at least here in the US, start with the letters TIPS. So you can automatically narrow it down to just 2 meds in these answers. So you have a 50% chance of just getting it right just by using this mnemonic. And then if you can remember, sertraline is an SSRI from the mnemonic we talked about before. Serpent, remember the snake charmer mnemonic. You know all that's left is phenelzine, an MAOI, and that's the correct answer for this question. Final question. Number 5, a 38-year-old female presents to the office to follow up on her recent diagnosis of depression. At the last visit, the decision was made to start psychotherapy, but she finds this to be ineffective and is seeking medication to improve her mood. She's not currently taking any prescription medication, denies a family history of depression, and has no other medical conditions. This will be her first time taking an antidepressant, and her only concern is the potential for weight gain, as she has struggled with her weight in the past. Which medication listed below would be most appropriate to start in this patient? A. Isocarboxazid, B. Doxepin, C. Amitriptyline, D. Fluoxetine, or E. Paroxetine. And the answer is going to be D. Fluoxetine. So we have a patient with no medical conditions who's going to start pharmacotherapy for depression. She hasn't tried any meds yet, so we know we start with our first-line meds. We know TCAs and MAOIs, they're never going to be first-line treatment for depression. So right off the bat, You can eliminate isocarboxazid, which is an MAOI. You can eliminate doxepin and amitriptyline, which are TCAs. So all we're left with is fluoxetine and paroxetine. So both of these are SSRIs. So which one's the right answer? Well, technically either one would be appropriate to treat her depression, but she did mention she's concerned about weight gain. And we know paroxetine is the SSRI associated with the most weight gain. Remember our fat parrot? And since this is a concern of hers, fluoxetine would be the most appropriate choice in this patient. All right, so that was your antidepressants. I hope that was helpful. Thank you so much. If you made it to the end of this video, I am very much impressed. Thank you as always, and good luck in school.